I'm Erin McGuire. I am a second-year PhD student at University of California in Davis, and I focused on developing a dynamic, localized care network. So I come from working in international development. I was working in the Global South on horticulture innovations for small-scale farmers. So this is really where a lot of this research intent comes from. But as we know in international development or community development at large, in order to provide adequate health, nutrition, education, and livelihoods, there needs to be innovation. And by that, I mean a system, technology, or knowledge base that disrupts what is currently available. And I think there is a general consensus that we need more systems approaches to generating solutions that work for each community, and that a dynamic and resilient innovation system generates effective or can create more effective solutions when they engage with local and regional communities and leadership. So this research really aims to understand how to engage and promote more leadership from local and regional communities and what prevents greater localization from occurring. So to engage more local entities, we think about decentralizing a network. Traditional international development models are hub and spoke networks with decision-making and funding done through a centralized mechanism, like a big ship. And this slide is from Anand Kitna, so thank you so much for that. And you can see on the left, the more centralized network, which is the classic international NGO or US Agency of International Development. But it's more like this massive ship that is being steered by a few people and everyone's going the same direction. And as you move towards the right to a more decentralized network, you see increased local leadership, increased independent funding, increased priority setting. The network becomes more nimble as power is really shifted from one large entity to many smaller and local entities. So to elevate local expertise and leadership, well, we all agree that this diversity and local leadership increases innovation and effective solutions. Nonetheless, women and non-white solutions are not as recognized as white male solutions. And so the challenge becomes, how do you disrupt the system or make change if the same power dynamics and expertise are driving the change? And CARE has really looked at this quite a bit. They are involved with the Delhi Resolution and the Cairo Compact. They have created these themselves to increase Global South membership. Also a signatory of the Charter for Change, which is around localizing humanitarian aid. And the 2030 Global Strategy highlights localization as well. So CARE has certainly taken on this challenge and this desire to localize. But beyond CARE's interest in localization and current steps to realize a more decentralized network, I was looking at this research in these past couple months in the face of COVID-19, where we saw the breakdown of globalization and a renewed importance of local systems resiliency. And also the Black Lives Matter movement in the United States, which really made me personally reflect as a professional in international development and as a researcher on how to approach localization and this decentralization question. So if there is so much talk and desire to localize, why isn't it happening as quickly as some might like? And so ultimately we decided to try to see if those in management and higher positions within the CARE network think differently about the challenges to localization than those that are in the field and maybe not as connected to the higher level conversations, but impacted and living out the policies every day. So we wanted to see what would happen if we gave a chance to staff to speak directly to the issue of localization by developing a survey. And how does that differ if you are in the Global South or Global North, those opinions? Or what part of the network you are in. If there are differences, potentially this discordance is slowing down the localization process And we also wanted to explore not just logistical challenges to localization, such as monitoring and evaluation, but also decision-making systems and institutional biases. So my structured interviews, I interviewed about 15 managers who handle and think a lot about localization, and pretty quickly, 3 different potential models for localization arose, which one is to keep the current model, promote country offices from within and make them member offices. So a good example of that is India, which became a candidate. And then another is remove country offices and care lead supports local organizations. A good example is Chrysalis, which became an affiliate through their own incorporation. And then remove lead country structure and become a completely decentralized network. And that an example of that might be Canada, who is choosing to step away from managing country offices. And then also the Middle East and North Africa hub is a great example of leadership and technical expertise that could be developed in any of these models. So using these interviews and knowledge base as a launch pad, we developed a survey to go to all care staff. These are preliminary results because the survey is still active and we're hoping to get more participation. So you will see a link that you can click on soon enough. But people were given definitions of 9 possible challenges to localization, which I'm happy to share with anyone who wants to see them. But here I've highlighted the 4 top challenges, which are aggregated. So I'm not showing you disaggregated between headquarters staff and non-headquarters staff at the moment. So care administrative policies, internal funding rules, decision-making systems, and institutional bias came up as the most significant challenges to care localizing. However, one of the more important aspects of this study is to identify differences in perspectives on challenges between those in headquarters and those in country offices and regional management units, and further between global north and global south. So here you can see that those and the country offices and regional management units really felt that care administration policies, oddly, were some of the bigger was a very significant challenge. Institutional bias and decision making as well. Another interesting thing when you disaggregate these data is that internal capacity building wasn't mentioned once as very significant by CI member or secretariat level network actors, but was seen as significant challenge to localization by country office and regional management units. And without that disaggregation, that challenge wouldn't have even risen to the top, as you can see on this slide. So already preliminary data is coming back interesting and I hope helpful. So, and when people were asked what was the most important challenge, they were able to provide qualitative answers. And I've gone ahead and highlighted some themes here for the most important challenges. So under care administrative policies, people really felt technical expertise should include Global South members, and that the bureaucracy and in care prevents Global South participation because of onerous systems, for example. For institutional bias, intellectual trust in Global North came up quite a bit, where Global South members not members, but Global South staff or survey participants didn't feel like there was a lot of trust in Global South expertise. The predominant English language use, leadership and personal awareness of historic neocolonialism and bias, and greater diversity and national representation in country office leadership. That arose quite frequently as well. And then internal funding, what you might expect, cost recovery, increased local funding, adhering to new funding protocols, and then in decision-making some systems being more Global South inclusive. This quote, I won't read it all to you, but I think it highlighted some of the bias people reported. In the end, we covered this bias by talking about risks, but it is still about control. The care member places more trust in their own staff member, however inexperienced. And then they also go on to talk about technical expertise is an inherent bias. So finally, we also included in the survey what can be done now, and people reported including global Southern perspectives and elevate national leadership, and that a great value add, no matter how localized the care network, is around fundraising, the advocacy, and knowledge brokering from members. And we are still very much looking for more participation. I think we already have some rich data, but I hope and think it would mean more if we got more voices. So I think Savannah is going to put the link to the survey in the chat box, and that's my big ask at the moment. And we will be sharing results when all the results are in November, as well as a journal article. And you're welcome to contact me with any questions. And I just have to give a huge thank you to CARE before I close out. Everyone has been so generous with their time and just being willing to look at this issue and follow me through the research question changes. So just a lot of gratitude and thanks.